Doc, I'm ready to go home.
All right, Phoebe, how are you feeling right now?
I'm feeling much better.
Is that helping?
Can I take some of that paste with me?
We'll see what we can do in a little bit. Right now I'm very concerned. We looked at your labs and your chest x-ray and your 12 lead. And you're having an inferior heart attack right now.
What? I'm having a heart attack?
It's going to be okay. You're in really good hands, and we've done everything
I'm having
right
a heart
to
attack.
take care of.
Am I going to die?
No.
You're sure I'm not going to die?
No, we're going to take really good care of you. Everyone around you has done a really good job. You're in good hands right now. We've called the cardiologist. He's on his way. But the labs and according to the 12 lead, that's what leads us to believe you have an inferior MI.
You're sure? I threw up on the way here. I really think I have the flu.
Sometimes that can happen with an MI because the heart sits next to your stomach and can irritate it if it's in pain.
So it's not my burgers.
What does she have to do for it?
The burgers are not helping your case, no. So we're going to have to call the cardiologist and they're going to evaluate your case. Might have to send you over to the cath lab and decide whether they can put some stents in there to open up those arteries to get blood to your heart better, or surgery, but he's a really good cardiologist.
Surgery? I might need surgery.
It's a possibility, but I think that you'll have good success and we'll hopefully just be able to do the cath lab, all right?
Okay.
The cardiologist is on his way. He's really good. He's one of the best in the state.
What about my convention?
I think we're going to have to postpone the convention for now until we make sure your heart's okay. That's what's most important right now.
Okay, well, Dad made it, so...
Yeah, Dad did good.
I am going to be okay.
You're going to be okay. We're going to take really good care of you. We've got the best team around.
Okay.
Labs and diagnostic. We ordered a CBC looking for signs of anemia and infection. We ordered a CMP looking at liver and renal function as well as hydration. We looked for any electrolyte abnormalities which can cause arrhythmias and contribute to abnormalities on the EKG. We looked at albumin for CYP and drug-drug interactions. We looked at the troponin to see if it was elevated. We also could have ordered a CK and B if troponin wasn't available, both being cardiac enzymes, to give an indication of a STEMI. We looked at the coags for any clotting or bleeding issues, so PT with PTT, PT, and INR. And because they're also going to the cath lab, so we want to make sure that if there are any bleeding or clotting issues that we're aware of that ahead of time. We looked at the 12 lead to look for ST elevation or signs of ischemia or prolonged QT. And we also looked at VR4 since we saw signs of an inferior MI on the 12 lead. A portable chest x-ray was looked at to rule out tension pneumothorax. And we also looked for cardiomegaly, signs of dissection, and pulmonary edema or consolidation that might be contributing to chest pain.
In the treatment of acute coronary syndrome, Mona greets the patient at the door, M being for morphine, O for oxygen, N for nitroglycerin, and A for aspirin. So in the case of Phoebe, the Mesa City bus driver, we immediately administered 2 milligrams of morphine initially, and based on monitoring her pain status, you can increase the dosage from there. For her oxygen treatment, you base that on the oxygen saturation level, and a good place to start is to place the patient on a nasal cannula set at a flow rate of 2 to 3 liters initially. For the nitroglycerin, a couple important things to note. If you suspect right ventricular involvement in myocardial infarction, it's important to monitor the patient for significant signs of hypotension, and if that is elicited, then you should discontinue nitroglycerin treatment or continue to monitor them very closely. With Phoebe, we placed 1 square inch of nitroglycerin on her chest and continued to monitor for signs of hypotension, and she progressed through her treatment just fine. Every patient should also receive 325 milligrams of aspirin with their chief complaint of chest pain. With Phoebe being on aspirin treatment daily, we went ahead and gave her another aspirin tablet just in case she had been non-compliant for the day. We consulted cardiology and informed them that we suspected ST elevation MI, and informed Phoebe that she would be transported to the cath lab, which was within 90 minutes of the hospital. If it was outside of a 90-minute radius, then we would consider thrombolytics.